evening. Welcome to Co-Produce Care, and we're going to have a really lively discussion this evening about managing medications in the community, and particularly for people who have home care provision of some kind. I've got a really exciting panel, so I hope that you're going to press like on Facebook, subscribe, and click the bell on YouTube, and maybe make some comments and questions in the box down the right, and you can see us on Twitter as well. So I'm going to get started. My name's Caroline Southgate, and I run a care company, home care company, based in Southend called Doris Jones, which was named after my grandmother. And we're at 10 years old this year. And I also have a NICE fellowship, and my particular project is to look at the NICE guidance and how we can make better use of it in terms of helping people to manage medications if they're having care in the community. So I'm going to get started by introducing my very exciting panel with a broad spectrum of knowledge and experience in this subject. So my first guest is Dr. Catherine Millington-Sanders, who is a GP. There she is. Catherine is the National Clinical Champion for End-of-Life Care and co-founder of a social enterprise called Difficult Conversations. She's a practicing GP, a clinical commissioner, and a specialty a doctor in palliative medication. So she's going to bring lots of experience of looking after people in the community. My second guest is Hooman Safaei, Director of Operations for Atlas EMR. Hi, Hooman. Atlas EMR are a company that are striving to solve the complex challenges of medications management across the care sector. And I'm sure he's going to have lots of interesting things to say about the complexity of that. Juliette Millard is with us, and she is Head of Clinical Governance for New Cross Healthcare, who are a nationwide provider of nurses, healthcare assistants, support workers, and they also have a home care service providing complex care, so lots of experience in the field. And finally, Tracey Ferguson, who is on the coalface as well as a home care provider for Home Instead in Bedford, and they look after 90 clients in their own home. And so she will be telling us all about what that feels like to help manage medications there. Hello, everybody. There you all are. That's exciting. So thanks for joining us. I wondered if we would start by having just to really give you a couple of minutes each just to tell us what your experience is of helping people with medications in their own home from your perspective. What does it feel like? What's the sort of status quo? Do you want to start, Catherine?
Thank you, Caroline. Well, as a GP, I mean, managing medications in the community for our patients is just such an important and integral part of what we do as a GP. With my special interest in looking after people with advanced serious illness and end-of-life care, I work with the Royal College of GPs and Marie Curie, and have looked at we've developed something called the Daffodil Standards, which is looking at quality improvement within general practice. And one of those focuses is around end-of-life care medication, and getting it right just can make all the difference. So in my usual job, I kind of will experience making sure that people have the right planned care. So you ask about what matters most to them, which medications they need. You try and ensure that those medications are organized in a timely way. They get them in anticipation of symptoms that they might need. And you see when that works really well. But equally, it's so distressing sometimes after a rapid discharge, or where things actually from hospital and things haven't gone necessarily as well. And when those things aren't in place, you can just see the real distress, both to patients and families and caregivers around them. So I really welcome discussion tonight, because I'm looking forward to seeing how we can all work better together and hearing each other's perspectives.
That's brilliant. Thank you. Should we go to Tracey? Tell us, Tracey, because you're not the prescriber and Catherine is. Tell us from your perspective with your 80 people. I'm assuming your clients are generally elderly people who need help, but I might be wrong.
No, absolutely. They're all elderly, vulnerable clients. And for that 80 clients, we're supporting medication for at least 50% of them. And for me, managing medication in domiciliary care is frustrating. It's absolutely soul destroying at times, because there's so little communication. And having experienced working in care homes, I know that the communication can be better. And as a manager now, managing domiciliary care, and I've done that for 7 years now, it's so difficult. It's like trying to pull hen's teeth, trying to get that information from doctors, from pharmacists, dealing with incorrect prescriptions, having to double guess whether this medication that's been delivered is actually the right medication. And very often we're having to manage that medication. I'm sure you come across this as well, Caroline, with the family members of those vulnerable people. And it's very difficult because they want to be involved as well. So sometimes it's like Chinese whispers. And it makes it really difficult because we are responsible for that safe administration of medication, but we're dealing with an unknown entity of a surprise bag of medication that's been delivered, and we just don't know if it's correct. And then we play the game of trying to find out, is this the right prescription? How can I check that? And who's going to communicate with me? Because very often that request for information is falling on deaf ears, and it's really frustrating, really difficult.
Yeah. Thanks, Tracey. I think it's that's exactly my experience in home care as well, is that whole mixture. So hopefully we'll elaborate on that. Let's hear from Juliette, because Juliette, you've got nurses who perhaps are prescribers and care workers or other people working in your teams. How is your experience similar to Tracey's, or?
Similar to Tracey and I guess to yours, Caroline, and we've got some 18 branches across England, Scotland and Wales, and our clients, our service users, their packages of care are managed by senior lead nurses or care associates who are obviously highly skilled, highly experienced. And I think they're the ones that are having that interface with the prescribers, with the GPs. Some of our service users, they have medication prescribed by different health professionals. So it's maybe not just the GP surgery that we're having to liaise with. It might be a hospital consultant as well.
Yeah, of course. Yeah.
Whether things like nutrition prescribed items come into this or not, then that adds another dimension, having to liaise with dietitians who are prescribing feeds as well. So it's complex. And Tracey, you mentioned care homes. My background up until 5 years ago was in care homes, and I actually helped contribute to the NICE guidance that came out in 2014 for care homes. And generally speaking, a care home is in the enviable position of dealing with one GP for all of their service users. Of course, for us in home care, we're dealing with almost as many different GP surgeries as we are with service users. So that adds a layer to the complexity. And of course, we're all trying to achieve the same regulatory compliance, regulatory, requirements and working in the way that we should. But I think that's often not understood.
No, it's very difficult. And I think if you look at the numbers of home care companies that achieve outstandingly safe, it's very, very few. I mean, there are 3% of home care companies, I think, become outstandingly recognised by the CQC overall, but safe is really hard to get, and that has a lot to do with how we prove to the regulatory bodies, how we prove we are indeed delivering meds. And I think this is where the technology and things might help us, which leads me perfectly to Hooman. So you are there with your tech team trying to tidy us all up and make something work. Tell us a bit more about your work at the moment. Where are you up to with this complex business?
Okay, so I think I resonate with you with all the frustrations and all the comments that the panel has made. I think as a tech company, we start out by trying to really understand the challenges, and the challenges that we see are, one, at the point of administering the medicines. So there might be errors or risk of errors at that point. There's a risk of errors at the dispensing and supply stage. And then there's risk of errors at the prescribing stage. And I'm not talking about clinical errors in prescribing. It's more, am I giving the current medication at the right dose to the right person? Those kind of errors. And then, as you've all said, regulators come, and who do they blame if something doesn't go quite right? It's the care providers, and there has to be accountability and safety there. The problem, as you've all said, is care providers they don't have the information to take that responsibility, even if they want to, you know. So those are the challenges that we see across all sectors to do with medicines management, whether it's care homes, whether it's hospitals, whether it's home care. And then, as Juliette says, there are some specific challenges with home care. So multiple GP surgeries, multiple pharmacies, you know, those are things. Also, the people providing the care aren't just the care agency. Like we've said, families get involved, and then the responsibility of different types of medicines management is shared as well.
Yeah, yeah.
So
I think we also then get that family-filled gossip box of doom, which I think fills us all with dread, because people want to be using these lovely, colourful plastic boxes, and what are we supposed to do with these? And it's so common.
Yeah, it really is, and we have to be really quite clear. But then, of course, if we're only doing 2 visits a day, and actually someone needs meds 4 times a day, then are we? You know, maybe they do need something to help them when they're on their own without care. So it'd be
lovely to see some more technology to help people. So things like the pivotals, to see something perhaps a little bit more up to date, something a little bit more innovative. And I know some of our clients have taken to using Alexa to give them prompts and reminders, which is great. Alexa can tell you when to take your tablet. But it's that physical support as well, that's something that would be really great to see sort of make an appearance in domiciliary care and medication, because it's sometimes specifically with those kind of time-specific medications, the Parkinson's medications, where perhaps somebody needs to take that at 6:45 in the morning, and we all know with domiciliary care that that's not really a great time in the morning for us to start our morning calls. So for those people that need that sort of really early morning medication, that's where we find a lot of people struggle.
Yeah, certainly. And in terms of the technology, I mean, let's move on a little bit to technology then, seeing as we've gone in that direction. I suppose the way, if we go right from the interface with the carer, so we for example, we've just added EMARs. Well, we're just about to go live with EMARs, which the information that's in our EMAR will still be from that bag of medicine or the green list that the family member hands over. And we might better get through to one of our 23 GP practices to check before we start delivering. But we might have to start care first thing tomorrow morning, having done our assessment today. So there is an element of trust, isn't there, that the information that you've got is correct. And then, you know, we all refine care plans once we get to know somebody. So the very first person that might have an interface with tech would be your manager or whoever does your assessing, and then your care worker who turns up and finds that in the kitchen cupboard there's 300 spare doses of something that's probably quite possibly out of date. I've taken a GP to someone's house once with a black sack to collect all the excess delivery of medication. So the care worker themselves, I mean, I wondered, Catherine, do you see that? Do you see how much medications being prescribed arriving in a house and what it feels like for people to deliver it? I'm not quite sure how much the GPs know about what we get up to.
I think we do see a lot of that. I mean, we're having to review all the prescriptions, so you get a feel of how much you're prescribing. You've also got sense checkers, and you work with your clinical pharmacists, often in the community and also in your practice as well. So, I mean, we're really lucky, I think, with the increasing workforce of clinical pharmacists and working much more as a team, and building the team in general practice has been very, very helpful. And also trusting your team that you play tag with as well, to know that they're able to come to you and go, have you looked, they're over X percentage potentially, and we need to review some of these things. So I think that's very important. I think the other part is when you go on home visits, you often see, I've seen lots of things in my, years, bags of things. You see things when people die and they've got unused medication or just things that they put in in odd places that they take on weird and wonderful stories. There are lots of ways that people store medications and who help them with medications. And so it's really important to have an element of trust, but also to be there to help people when they need support, and be there as a listening ear when they ring you to say, I've got too much or too little of something specifically.
Yes. I do quite a lot of shouting at the radio sometimes when they say, you know, you can't have paracetamol prescribed. But actually, if you're a care company delivering care to someone with arthritis that needs paracetamol every 4 hours to get through the day and stay mobile, we have to have a prescription for it because we need hundreds of them, and you physically can't buy them in the shops. I think there's lots of misunderstanding around volume and stocks and things like that. Hooman, in your tech for care homes, of course, you've been able to tidy that up a lot, haven't you?
Well, yes, we have. I mean, we've got solutions for most of the challenges. So the solution of making sure the right medicine is given to the right person at the right time, we have an EMR, but the safety element is the EMR scans the barcode on the pharmacy's dispensing label, and it checks that validates that's the right medicine to the right person given at the right time. So physically, you know, as care providers, it's the right medicine going to the right person at the right time. And we employ the same technology at the dispensing stage at the pharmacy, so that, you know, there are dispensing errors at the pharmacy. I'm a pharmacist, and we're human. We all make errors. And it's great to have a system of barcode validation to make sure we're giving the right thing to the right person at the right time. So now the EMR also records information, who's taking what, if that dose has been administered or been refused, or not being given because there isn't a supply. Now, Catherine, as a clinician, you would like to have that information, right? You'd like to see who's been taking what and who's not been taking what, because you know you've prescribed it, but you don't know whether it's been taken and whether it's been taken as you intend it. So technology can capture all that information, and it can share all that information. And Tracey, you mentioned you're often blinded. You're blind, you don't have the information, but technology can share all of that. And around prescribing, it's the errors or anomalies or discrepancies that I see is, you know, a clinician has changed the dosage at some stage, but the repeat prescription data hasn't been updated. So next time the care organisation requests a prescription, they get a prescription with the old data. And you know, the solution is, well, let's have clinical pharmacists do this, that. Let's bring in medicines with reconciliation and all of that. But it's all physical things reliant on human beings doing these steps. And you know, whilst, you know, individuals are very good at everything, but that's not, you know, technology can be much more consistent. Technology can share the information and consistently prevent these kind of errors and reduce the risks.
Yeah. Have any of you seen an impact from having an NHS email address if you're a non-NHS? So we managed to do the data toolkit thing for security, and so we've now got NHS email address. That has helped communicate with prescribers a bit. People are answering questions more easily. Juliette, have you got that?
Yes, we've found that our office staff, our office nurses, and have access to NHS emails, which helps enormously with the communication with GP surgeries. But we use an electronic care planning system, which includes an electronic medication administration record process as well. And the company that provides it, they are, I think, unique, and they provide us with something called GP Connect. So where service users have consented to their NHS records being shared, we can gain access to their GP records. So it's a live link, and we can see exactly what is on their prescription list right now, which is fabulous. And it has completely revolutionized how we manage medication management on a monthly basis, because we're not having to chase the GP surgery every month. Can you give us an up-to-date list? Because we can access it. It's amazing.
That's a huge leap, isn't it? I suspect anyone who's tuned into this discussion will be thinking, I want that. How do I get that? So we can probably follow that one up with how we enable people to do that. But does it depend on each GP practice or CCG having you sort of develop those relationships to make that happen?
I think it is, yes. I think there is an element of that, and obviously not every service user has consented for that. So, we will find people that we don't have that access to, and we've got to revert back to what we did before. Of course, it's the information is still only as good as it's kept up to date. I don't know how you manage in your surgery, Catherine, but sometimes things don't get removed off prescription lists. We're very well aware of that. And we also have the situation where some of our families, particularly parents, will be a lot more flexible with what they want their children to have, dose administrations. And of course, we can't necessarily work along with that. We have to have it in writing. We can't just take it from the family. Oh, we've decided to stop this, start that, reduce the dose, double the dose. That's not how it works. And as I said earlier, there is this element of, does everyone we're working with, including the service user and their family, understand how we need to operate and why we need to do that?
That's a big part of the relationship, isn't it? Is that you're a trusted pair of hands to look after their loved one or their relative or the person that they've got attorney for, and so you've got this huge element of trust. You bring people in off the street with great values to become care workers and trust them which in any other setting you would have these, so particularly things like controlled drugs, those end-of-life medications where in any other setting would be under lock and key with a log to make sure that they were very, very carefully measured and controlled drugs situation, and yet they're in the kitchen cupboard with all and sundry coming and going and visiting. And we have a safeguarding duty too, and so one in however many will be perhaps someone who isn't benevolent and is trying to double the dose in order to have mum asleep by 5 o'clock in the evening when they come home from work, so that they're no trouble in the evening. I've had that. There are some sad situations that we deal with. So I think we can accept in this conversation certainly that we recognise that the care providers, the home care providers, have got individuals that are living with a level of risk because they're in a domestic environment. They're living with a level of risk, aren't they, for lots of things, whether it's, mobility or choosing to live in a cold house or a hot house. I mean, the hot house is quite difficult to work in for some people, but all those different things that people have chosen, and we must allow them to choose. People have mental capacity or not, but lots of decisions about refusing medications, having them at 5 to 1
also,
or 5
Caroline, it's about the caregivers. So when you think about in a care home setting, the controlled drugs are locked away, they have to be double checked, 2 members of staff count them in, count them out. It's very controlled and measured, and there are safeguards in place to protect not only the residents but also the staff that work there. Then we come back to domiciliary care, and there's absolutely no framework. There is no double checking. There is no counting in and out. There is no secondary person. So those caregivers that work in domiciliary care are on their own. And when something goes wrong, all eyes are on them because they haven't got that double check system. And it always has struck me as quite strange that we don't monitor and control drugs better in community care, because if we feel the need for it in a residential setting, in a nursing home setting, why isn't there any regulation and framework for community care when you've actually got more people in and out of the property, more need for that regulation and safe storage of those controlled drugs? I mean, I've had medication posted through clients' letterboxes in syringe format for the client to be self-injected. And you just think, seriously, you know, we're posting a syringe of medication through a letterbox, or we're just leaving a bottle of Oromorph on the side, and there's absolutely no control as to how much has been dispensed, who's dispensing it. It's just there on the side, and that just seems really, really dangerous.
Yes, on occasions, Tracey, with particular individuals where there has been an identified higher risk, we have actually gone about keeping our own records, similar to a nursing home or care home would. So we do have some kind of account. But of course, you know, we may not be the only care provider in somebody's home. We might be administering medicines along with another agency, or the family administering medications. And whilst I think we're all used to having used paper records, paper MAR charts, and you know, families, the other agency could see what had been administered when. Now that we're using an electronic system, it's much less visible to others.
Yeah, that's a really interesting point, Catherine. If you're helping someone with the medications around end of life, in your daffodil standards, have you come across some of the hiccups with that? I mean, some of those things are injectable or infused drugs, and we perhaps home care providers are not. We're not involved. Generally, we're not involved with those, but we're alongside them, and things like drugs to stop secretions and things like that might be being given. How does that fit with the daffodil standards that you were talking about?
So what we've developed is a system. There are 3 levels, and it's working with GP practices to basically help them. Level 1 is about collecting their data, understanding the processes to give consistent care to all people with end-of-life care needs, and then making sure all of your team members understand the importance. So that's not just within your team, but it's also the wider team that you work with. So in theory, that would be caregivers as well. Part of those, you also identify carers and caregivers. So by virtue, sometimes the really important part is that when a caregiver rings in, and they're already flagged that there's someone important, that this person has end-of-life care medication or end-of-life care needs. And so you start to create a system with consistent coding and data. Then the next part is looking at your MDT. So when you're talking about patients, making sure that we can, if we've identified people, so both patient and their caregivers, then we can more consistently start to plan against what's best practice. So what are we looking for? When people die, do we reflect on level 2 on how they've died, if they've had the right medicines in place, what those medicines have been, if their symptoms have been well controlled, if their family have said they had a good experience and their needs were listened to. And then also just being able to have better communication. So a key part of it is communication and involvement with key people that are important. So that's patients, teams, and caregivers. So it's really trying to have the reflection on how to understand how you make those improvements. And we all know that in different areas of practice, we can all do better. So it's really just understanding what you're doing really well, and then being able to build on areas that you highlight, because you're starting to build a process of data collection and evidencing. And I'm sure technology from Hooman probably would help us as well, make that easier.
Yeah. And so the other thing that strikes me then is that the COVID impact, dare I mention it, is that we haven't seen. I mean, Catherine, we're not going to put you in the stocks or anything, but where I am, we haven't seen a GP come out for a very long time. They've been sort of locked up. I think we've been in masks, don't know where they've been, but they haven't been out visiting in the same way. And I think that we've really suffered with that. And I with my new NICE fellowship and my new hat on, which is really to look at the guidance around managing meds in the home when people have home care. I really hope that we will emerge from this COVID period with perhaps certainly some of our GP colleagues having a better understanding of what it is we're actually in the business of doing, so that we can open up that conversation, because we have to join the queue, I think, with everybody else at 8 o'clock in the morning on the telephone to give that feedback or to ask that question. And it's some of the physical problems of actually getting that information are, Tracey, I think you said right at the beginning how frustrating it is, and I think that there must be a will. There's 5 of us here representing quite a lot of people in the sector. There must be a will to have that. We're all in this business to care for people. We actually are all we're all vocational in social care and health. That's what we went into this for. And we seem to have lost our way of communicating with each other and giving that feedback, because it's quite a tricky relationship, isn't it? Where do I find a place to give feedback to, say, a GP practice where someone hasn't had a very good experience at the last few days or couple of weeks of their life? My only resource is a complaint. And I think that's a bit sad, really, because I think I'd much rather have a debrief that allows me to reflect with the rest of the MDT, which could be the palliative nurses, it could be something to do with the hospice team coming and going. So I think perhaps one of the solutions to some of this is better feedback loops. Same with the hospital. Actually, we have I don't know if you have the same experience. Hooman, with the discharges with hospital medications, is there something about the digital meds information coming from hospitals that might be in the pipeline, because it would help too?
Well, it's I think it's the systems that we are all operating in. We're all passionate about what we do, but the systems are limiting us. The systems don't allow the communications. Well, it might be digital, but it's not shared amongst all of us. So
the trouble is, it's been on the cards for so many years. I think I've lost count. I've given up hope of waiting for the government to say, let's have a joined up digital system. And what always seems to happen, and I've lost count of how many clinical commissioning group webinars that I've sat in on that are specifically designed for care homes and supporting with care home management. And what they always say, when I always say my piece, is, oh, we hadn't thought about domiciliary care, because, and even throughout COVID, domiciliary care was at the very bottom of the list because we weren't thought about. And I think that is the pivotal problem with medication in domiciliary care and technology and improving things, is what we really need is for government, for everybody to recognise that domiciliary care is a really important, very large section of the care industry, and people need to stop talking about care homes as the only template and format for how care is delivered.
Absolutely. And I think, we find sometimes when our service users are admitted to hospital, our staff are commissioned to go in and support them in hospital as well. Doesn't happen all the time, but it does happen. So we might have had a service user in hospital for a week, 2 weeks, and they've had a member of our staff with them, throughout the day, perhaps even 24/7 for the whole of that time. And we still don't get any discharge information. We still don't even get told how their care has changed, because we're not recognised by the hospital staff.
Yeah.
And that's so sad, because we are such an integral part of that individual's life in their home.
Absolutely.
And we're going to stop them bouncing.
Exactly the same.
Yeah. And we're going to stop them bouncing back into hospital, aren't we? That's the reality, is if we don't get it right. So I suppose if you play devil's advocate, the thing is, do we ask? Well, I know the answer in my office, because they ask quite a lot, but it's like, how can we ask better for what we need? And this sort of, I think the nice thing about co-produce care, offering for us to take over and have a panel discussion is to make sure that we have these discussions and start the process of asking. There must be generations of home care providers have been asking before us. The reality of COVID is that we're all in my front room today and we haven't got a big meeting, and we've managed to get to a situation where actually we can have these conversations in real time at 7:30 on a Wednesday evening in the chief exec and the head office, and we haven't got to wait too much. And I think that the people who have the ability to change things, so maybe that's commissioners, but maybe it's just a ward sister who's a bit more interested in finding out. Maybe it's the receptionist at the GP service that we need to talk to about, look, this is us. You know, we've got a couple of GP practices in Southend who know us really well, and I don't think my girls have any trouble at all on the phone in the morning getting through to a couple of them. But then sometimes it's just, well, we don't know who you are. You're not the power of attorney, or you're not the person we can talk to.
It's the visibility of domiciliary care.
Yes.
It needs to be more visible, and I think that we need to start taking that conversation higher up. It needs to go to government level, and it needs to come from that point down, because if every single care provider battles on their own grounds to try and create better communication, it will only be localized. And what we need is national joined up communication, national sharing of information. And it's sad, because even within the NHS, those agencies don't all share information effectively. Paramedics don't share information effectively. Hospitals don't share information. And it's really sad. We've got so many separate silos, separate databases, separate systems. And I've always said it's incredibly sad when paramedics are called out to somebody vulnerable who's had a fall. They perhaps can't ask them what's wrong. They don't know if they've got a care provider. They don't know what the medication is. They don't know what the treatment is, who's supporting this person. That person then gets put in an ambulance, taken to A&E. And then it's a guessing game as to who gets communicated with. And if you are the care provider supporting that person, what you'll sometimes find is a note left in their house when that person's been brought back home, just saying, oh, just to let you know, paramedics came out. You know, and they don't have the key safe numbers. They don't have any of the next of kin details. It's just a really segregated system. And I think that in order for it to improve dramatically, it has to come from a much higher platform, and there has to be some funding, serious funding, put in that direction, and recognising domiciliary care and all of the other ancillary supports that we have in the community, so that we can share information on a unified database.
Yeah, actually, Jamie's just made a comment in the comments box saying the problem with private providers is confidentiality of patients, which is why there's a lack of, I'm assuming it means information of discharge. Actually, in the NICE guidance, it very clearly states that the best practice is that domiciliary care providers who are CQC regulated, we have got permission from the people that we look after to talk to people about their medication. That comes as given, that if we've taken responsibility for helping them with medication, actually the NHS teams, whoever they are, whether in a hospital or in a doctor's practice, can talk to us and should, and it's all in black and white. And I think probably, if I have a 3-year project on helping to help to get underneath the skin of why perhaps there is some mismatch between what the guidance says very clearly that these people can talk to us as home care providers, but they don't. And I think that is absolutely key. And I agree. Jamie's also said dom care is the poor relation of residential care, and it should change.
Absolutely.
And I think he's right. And I think when you look at commissioning on time and there are lots of issues. And if we really could be here till midnight, couldn't we? I know that the UK HCA, for example, has they've got over 3,000 individual home care businesses who provide home care across the UK, and they've got every year they very carefully work out the minimum cost of an hour of care so that you can run the business properly, you can pay staff properly, you can do supervision and training and audit. And you can't do that if the hourly rate that you're paid commissioned is £15.50 an hour. It's not enough to run the business of this very complex service. And so you're right, the commissioning, the demand on commissioning, things like National Living Wage Foundation, the development of staff. I mean, if we went to training of home care staff, for example, as a subject, I mean, the basic minimum of the care certificate, the introduction to being in this job is nowhere near a degree in nursing. And actually the responsibility of walking into that house and giving that medication is actually quite loaded, because if you're a nurse on a ward with a red apron that says do not disturb, and actually walk into a house and you've got things going on in the kitchen and the dog barking and people visiting, and actually you're slightly distracted and you get it wrong, it still remains your responsibility. And yet you haven't got the time necessarily to take your time, shut the door, concentrate on which tablets you're taking out of the packet. So the actual practicalities and the legislation and the commissioning is a really big subject, and I'm really pleased you've been here to have at least this version of this conversation.
I think it's pressure on those care staff as well, working out in the community. I mean, the amount of times, and I'm not going to put the number out there because it is shocking, the amount of times that a prescription has been posted through a client's door, and my team has checked that prescription, looked at our EMR and said, hold on a minute, there's a different tablet in here.
It's different.
And there are lots, I mean, I've worked in the care industry for over 22 years, and I've worked for lots of different care providers, and there are lots of care companies where that situation would result in that care worker phoning up the office and saying, just to let you know, this person's got a new tablet, can you add that to the EMR? And that's exactly what would happen, and then that medication would be administered. But on these occasions where these prescriptions have been posted through doors, they were the wrong prescription that had been dispensed and delivered. And if it hadn't have been for the intelligence and the insight of the caregivers in our team to actually recognise, hang on, first of all, this doesn't match. Second of all, I don't think this person actually takes this medication anymore. We weren't told anything about it. And it's only because we happen to manage that person's care in such an autonomous way that we know the situation. Now, if that person had one call a week and family were involved, we would have absolutely no idea. And it's exactly. Countless times that happens, and that responsibility really shouldn't be on those caregivers' shoulders to have to pick up on those mistakes and errors. And they're very scarily frequent.
Yes.
The GP perspective, I'm listening to everything, and I think sometimes different perspectives can be quite misunderstood. So I mean, it's really helpful just hearing each of you talk about the difficulties that you're actually facing. And I suppose after thinking of on our normal, there was a Pulse GP poll, I think in 2009, where the average length of the GP day was sort of a double clinical shift and then at least 3 hours, so about 11 hours. Most people are having it, well, it was on average, I think, sort of 45 contacts, but so many, 1 in 10 were like having 60 to 70, which was thought to be unsafe, and the safe level was 30 contacts a day. And just the vast number of prescriptions that we have to look through and the calls that we're doing and starting, I bounce out of bed in the morning. I am shattered by the time I go to sleep at night. I work just like hard as I possibly can, and still I want to do better every day. And I want to be able to be in contact with the people that really need it. And the pressures on our time are just ridiculous. And then hearing you're all saying exactly the same. I mean, Martin Marshall, our chair for RCGP, did a brilliant sort of blog about relationship-based medicine. And I think we individually have our significant issues, our significant pressures. But some of it is, that would frustrate me so greatly to know when things have been changed or things don't work, and to not know that you can't actually get hold of the GP to be able to get hold of and tell me about that. Or you can't, you're a long wait to potentially, if you're calling the reception staff, and if you can't get it quick enough, and communication between and relationships between, our GPs and our caregivers, our GPs and our clinical pharmacists, and caregivers also and the clinical pharmacists. So, community pharmacists are so fantastic often at doing the organisation when you build the relationships. So I think a key part is, or a question really, is how do we not only do quality improvement, so we make it continuously better, because we know that we're working at different starting levels in different practices with different care providers, and how do we actually build our relationships? So actually there's a system that responds to our relationships, and some of that I think at the government level, but I think an important part is just encouraging us all to make those personal connections, and to let the GP know. I think it's really difficult, just as when there are different GPs for different care homes, if there are different people going into different patients, that makes it even more difficult than if you've got one or two that are there, they're regular responders. But if you are regular responders, it's how do you build the relationship with the receptionist? I'm important in this person's life, and I need to get access to you sometimes quickly, or I need those medications and they get regular urine infections, they get regular cellulitis. I'm going to need to make sure I get that anticipatory medicine. And just a little plug for my fellow, I had a lovely email from a GP today, and she was like, I've been visiting face-to-face all my end-of-life care patients throughout COVID, and there are lots of us that have done so much.
Good. Yes.
And I know we're transitioning, but there are just
I think it's really important to, and I think that's absolutely right. This is a country full of very dedicated health and social care professionals, for sure. We are extraordinarily lucky. We've got. I certainly had my jab by a consultant orthopedic surgeon who was doing an extra shift of injecting COVID vaccine. I mean, people are really putting themselves out every day to do their job. I just want to go back to the comments because we've got sort of 10 minutes before we finish. Angela Day has commented that, and we made quite a good point about nurse education versus domiciliary care training, and on the support. She's been involved in both, and so much can be done, but I believe it's essential, as Tracey says, to have both government policy and monetary commitment and on the ground systems and support. I think we are a strong voice for being the solution. And if I may plug the Institute for Health and Social Care Management's event in a couple of weeks' time, which is around We Are the Solution, and trying to gather professionals together to really listen to the fact that we have got the solutions. I mean, I know that my care team know those clients. They are regular visitors. I know that New Cross and Home Instead will, all over the country, will have care workers who go in and out of houses. They know the difference between a client on Monday morning who's a little bit more confused and is brewing some sort of infection. And so they will respond to that. They're very well trained. They're very well trained and very well supported by their home care managers. And we need to talk to each other way more locally as well. We can have government policy because there is nice guidance. It's sitting there. It's not brand new. It's been there since 2017. The version that's live at the moment, NG67. It describes perfectly what should be happening. So there is guidance, and there is we are making a living out of. I mean, let's be real about this. We are making a living out of delivering care, and we have lots of duties of care, lots of responsibility. But we also have to be able to pick up the phone and talk to each other and set up these meetings. And we're here, aren't we, doing exactly that? Jamie,
I think it's sad that CQC even openly admit that they know that there are hundreds and thousands. I think it was like 500,000, wasn't it, medication errors in community care, and that they recognise, acknowledge that that's going to happen.
Yes, but there are also tens of thousands of mistakes made by fully qualified nurses on hospital boards too. And so I think we need to be really mindful of the fact that, as Hooman said, these are human beings who can open the packet and make a mistake. So I think that one of the things that we certainly generate in our business in Doris is a no blame culture around meds, to try and make sure that you have openness about it. So one of the good things about the CQC knowing that there's been 500,000 mistakes is that people have admitted to them. What if you make that discipline around medication too draconian? What you end up with is people pretending they haven't made a mistake, which I think is far worse.
What we need to do is reduce the amount of mistakes would be the ideal. That's the goal, because we don't want the mistakes. It's not about blaming people and saying, oh gosh, you're a terrible workforce, you've made mistakes. It's about reducing the number of those incidents. And if we had better communication, if we had better systems, then surely that would see a reduction in those errors. And mistakes will happen, absolutely. But I would love to see less of those.
Technology can absolutely be used to reduce the rate of errors. I've proven it before in care homes with the introduction of technology. And as I said, we've got a technological email system, as Caroline, I think you said as well, and it definitely helps because it's real-time information. So our office nurses and care associates, they can see when a medication hasn't been given or there's some anomaly, whereas on a paper system you don't pick that up until you go and review the paper march-on at the week or the end of the month. So technology is, I think, a really useful and really positive tool, but there's still a long way to go. I think we're very much in the infancy of using technology. And I know I mentioned earlier the system that we've got where we can access GP records, but that could be developed a lot further. We can't communicate to the GP surgery via it. It doesn't tell us when something new has been added or anything has been changed. So there is a long way to go, and of course it doesn't include hospital discharge records either.
And there are lots of other prescribers, aren't there? We have dementia nurses who prescribe and paramedics who prescribe, and I think, you know, there are lots of people feeding into people's medicines in their home. I just wonder if we've got a few minutes to round up. I'm just going to check the other comments. So Jamie made another comment. He works in Wales, slightly different regulations, although similar. And he says he can echo the same difficulties and frustrations there in Wales. Unfortunately, the main issue is funding and staffing levels with health and social care, which is central government failure to properly fund our vocation. I don't think you're ever going to find anyone is going to argue with that, Jamie. I think you have to look at things very clearly about the workforce planning, the career in care. Is this a career? I'm a physiotherapist, and I moved into social care because I could absolutely see a need for the way I was trained as a physiotherapist about problem solving and solution focused and exercises. And, I actually think that, some of the allied health professions are really well suited, or would be really well suited to work in this environment. But if you look at the pay schedules and you look at the career progression, it's very, very different in social care in terms
There's
of...
also a real lack of managers coming into domiciliary care. You know, there's a real hole that's been created, and whether that's partly due to COVID, partly due to the stress and the pressure, but there's an absolute dire need for really good quality managers to be supported and progressed into community care, for it to be seen as a really good career progression, to be recognised, to be put on a platform, really. And I speak to my skills for care locality manager, and I work quite closely with them. And it's, so many managers, I'm in so many different forums, and all I hear is this sort of, oh gosh, it's really hard, it's really difficult. And the frustration, I think, just gets too much for some managers.
Yes, and I think Jamie's just made a very good point that he's ex-military. One of the things that I was very blessed with through COVID was that NHS people made a fabulous offer of mentoring from the army to care managers, and I was mentored through COVID by a lieutenant general based in Turkey, second in command of NATO's land troops and me, and it was wonderful interoperability of great people management skills, real insight into what it felt like to be leading in a crisis. And it certainly made me realise that actually our trawl for management experience doesn't have to come just from the ranks of someone who has been a carer. And I would highly recommend this sector as a place to work. When you've got great experience, if you're a good people manager, you can learn the stuff around the subject. But what we need is, as you say, strong leadership. And I suspect that if we got more of that, we would have more voice, because if we are full of exhausted people who are rather frustrated and fed up, trying to stay positive and be a force for good is quite tricky, isn't it? But I'm going to finish there, because I think we've done extremely well here. I think we've managed to knock out the problems, not be too negative, because I think when you've got, where there's a will, there's a way, isn't there? And I think if we can have engendered some conversation around this subject. Obviously, if people are watching this either live or perhaps as a recording, it might inspire people to get in touch with any one of us to say, yes, we agree with this subject, and get in touch with Co-Produce Care. You can email us, and you can go onto Twitter, and you can do all those things, all the social media. Comment on Twitter. There you are. There's the hashtag #CareUncut. And we'll definitely bring this subject up again. It's not going to go away. I've got 3 years with NICE, which is a real privilege. So I shall be back, hopefully. And yes, and Juliette has. She has a NICE. Juliette's also a NICE fellow. We love that signature on our email. It opens doors, and it's made people sit up and listen. And I'm certainly going to be trundling over to see Catherine and see if I can talk to her and find out if some of the GPs in that part of the world would be interested. And Hooman, you just keep going with the digital. We need a digital solution that solves all these problems of all the. I've got 23 GP practices in Southend. So if you can solve that problem, and we've been on top of that one, we'd buy your system.
We'll keep trying.
Yeah, excellent. Thank you so much. Is there anybody parting shot anybody wants to offer? You've all been amazing. Thank you so much.
About It's about developing relationships, isn't it? I think that's the takeaway, the relationships and using technology wisely. And thank you also to everyone who's made comments.
Yes, absolutely brilliant. And I can see some familiar names in there. And actually, Angela, I think if it's the same Angela Day, was the person who got me into physio school on a course. I did an access course as a mature student to get in to do physiotherapy. And Angela was the nurse trainer who did that very first access course. So if it's the same Angela, I'm really pleased you're there. Lovely comment. So that was good, wasn't it? Look how far we've come. And we will finish there. And thank you so much to all of you. And thanks to co-produce Care for letting us sort of jump in onto their panel and have this really interesting discussion. And we will call it a day and let everybody go off and walk the dog, I think. Thank you very much indeed. Bye, everybody.
Bye.
Bye-bye.
Bye.